And next we have Darin Nevin, who is the medical director, Providence Sacred Heart Medical Center in Spokane, Washington, who's going to be speaking about a randomized controlled trial of citywide emergency department care coordination.
Hi, my name is Darin Nevin, and I'm a practicing emergency physician about 5-hour drive from here on the extreme east side of Washington. And I'm going to talk about a study that we did in tandem, and it was funded in tandem with Chris' group in North Carolina. And our study has a few major differences, but it follows the same lines. Our study was also a 12-month study, and these are very preliminary results. The study just ended in July, so we don't have all the results yet. Our study also was a waived consent study. We did not tell the patients they were enrolled, and a little difference in ours is we didn't tell the doctors either, but they could probably figure it out pretty easy. So the problem is what we're all here to talk about. Patients with chronic pain problems go around to ERs and get multiple prescriptions from multiple doctors. We think that represents high-dose unsupervised therapy, which is dangerous. What we're here to talk about really is our approach, which is really informing the doctor with a lot of salient information in what we call an ED care guideline and engaging the community, but in also engaging every single hospital in town. So once people are in our program, they can go to any hospital in our metropolitan area, which is about a 250,000 size area. There were 3 hospitals at the start of the study. We grew ER, and by the end we had a freestanding ER, and we had 4, but they remained under surveillance. And so no matter what hospital they went to, we knew about it and we intervened. So that's the approach I'm going to talk about. And this started out of some previous work that I started in 2006 in Spokane, where we did this approach, and we've been doing it for about 7 years. We've been doing it on all frequent users, not just pain users. This study only focused on frequent pain users, people that come to the ER more than 50% of the time for pain. But we've enrolled over 1,200 patients in our program in Spokane, but it's never been studied in a randomized controlled fashion like this. So to be eligible, you had to be over 18, and you had to have more than 50% of your visits for pain. And this is the standard litany of things that you come to the ER for that most of the patients in the study had. The treatment group, this was our intervention, and it was a 5-point intervention. And the crux of it was we made this care plan. And that's where we went through the medical records of all 3 hospitals, and we went through all their ER visits and tried to find the drivers for their ER visits. No big surprise. It was a lot of addiction. It was a lot of chronic pain, maybe some pseudo-addiction, and a fair amount of mental health. And we documented that in a succinct way in a document, and we made that available to the ER doctor immediately when the patients came in. But we also made that plan not in a vacuum. We had a community meeting, and everyone in the study was presented before a community meeting, not only of representatives from the 3 hospitals, but community agencies that I'll list off here that also helped us address the drivers of these folks. Then we contacted the doctor for everyone. We called everyone's doctor and said, did you know they're coming to the ER? How can you help us? And we took their input. And we also attempted to contact the patient. We didn't measure how many times we got a hold of them, but we feel like we got a hold of them about 70% of the time. I don't know how often they hung up on us, but there's a percentage of that. Then when they came back to the ER, we had a ER case manager meet with the patient after the medical screening exam. Only 1 hospital had an ER case manager or social worker when this started. The study paid for a quarter-time ER social worker at the other 2 hospitals, which ended up hiring a full-time person. So a small component of this was every time they came in, we tried to address their ER use during business hours when the case manager was on duty. And then, of course, the doctor got the care plan when they came back into the hospital, so the doctor could always do the reinforcement. The control group was basically benign neglect. It was observation. It was none of the above. There was no special anything done for the control group. We didn't assemble any information. We didn't contact anyone. All we did was monitor them to see if they were getting suicidal. And if they had a suicidal ER visit, then they went to our medical director and they were removed usually from the study because we didn't want to have this study be unduly stressful and cause a suicide death. So these are our primary aims. They're pretty much the same: to see if our intervention reduces visits, to see if our intervention impacts ER doctor prescribing, to see if our intervention has an impact on overdoses, We knew we weren't going to make that, but we had to measure it and try. And then we did 2 other analyses. One's an economic analysis to see if this is cost effective, and another one we dreamed up during the study because we got access to this great database to look up people's criminal records, and we're going to be able to report later, you know, how many of these people have significant criminal records. These are the exclusion criteria. 2 of the hospitals had very rudimentary programs like this that did not communicate with any other hospital, where they put together a basic care plan, and if they already had that, then we didn't enroll those folks. If they had a cancer diagnosis, they weren't enrolled, and if they were suicidal in the last 30 days. So what we did was we combined the census from all 3 ERs in the city and took the number 1 patient that had the most ER visits and the number 2 and the number 3, and we worked our way down and looked up all their ER visits and made sure that everybody had at least 50% of their visits for pain. So we didn't enroll serial inebriates if, you know, 75% of the time they just came in drunk and they weren't asking for pain medicine. We whittled that 255 down to 165, and then we split it into 2 groups. So this is a little more detail on our treatment protocol. These are the things that our care plan has in it. First and foremost is security. Some of these folks can get verbally aggressive, but quite honestly, they can get physically aggressive, and they have destroyed hospital property, and that should be the first thing we think on the care plan, that they know that that's a factor. The second really most important thing here is this opioid recommendation. The crux of our care plan is a community has reviewed your behavior and has reviewed your medical history, and we feel that your repeated visits to the ER do not deserve the benefit of the doubt anymore. In the absence of objective findings like bleeding, bruising, scarring, vital sign changes, things that doctors can objectively, you know, attribute to pain, if you don't have those, this committee thinks that you should go back to the above described primary care provider or specialist to get your pain medicine. And that's kind of the crux of our care guidelines that we hope will encourage the doctor not to prescribe, and eventually the patient will figure out it's not going to work to go to the ER. We also summarized their past medical history, their primary care provider. We made a statement about how many CAT scans they have, because a lot of these people get a lot of CAT scans, and the hospitals don't communicate with their radiology system, so it's good to know if they've had 12 CAT scans in the last year. We stated if they're on chronic pain medicines already, because that's a reasonable reason why you shouldn't get another 20 hydrocodone if you're already getting 150 a month. And we summarized their ER visits, and we said who their specialists were. These are the people that are on our community care team that met every month, and they kind of divided and conquered these people that are really chaotic lifestyle folks. And any one person, if you read their histories, it's completely overwhelming. But these community meetings are so energizing because you'll have someone from Child Protective Services who has a tidbit of information, and that's probably a little bit of leverage too if they have a Child Protective Services case. You'll have someone from mental health who has previously engaged them and is willing to engage them in the past. All these different people can add their 2 cents and also do a little consultation with the patient if they feel it's appropriate. Then we contacted every provider by telephone and explained the process and got their input. Then we tried to call every patient, and we did send every patient a letter. Then when the patient came back to the ER, if the social worker was on duty, they met them afterwards and addressed the drivers for their ER use. And of course, when they came into the ER, we used a system. We have a computerized system where all the ERs are linked in real time. And as soon as a person registers, their name goes to a central server, and an alarm would go off if they're in the study or if they have a care plan, and a fax would come back to that ER with this care plan. We started that system in Spokane with a Meditech, which is kind of like an Epic hospital system, and then we switched to another system for the study, and actually during the study, the state mandated this system be spread throughout the entire state. So now the system is in every single ER in the state of Washington, which is kind of nice. All ER visits are logged in real time in the state of Washington, which is not done anywhere in the country to my knowledge. So this is what a care plan looks like real quick. This is the facts. This is a summary of their doctors. Of course, everything's redacted out. That's PHI. This is the opioid recommendation. This person, you can see, is already getting 150 oxycodone 10s monthly. So that would really influence me as to whether they couldn't just take a couple extra of those or talk to their doctor. That's really important information in my mind. And here it says that they've already been discharged from so-and-so doctor for breaking a pain contract. So that kind of paints a picture too. But it does say they have all these specialists. So if you deny them opioids as an ER provider, I'm comfortable knowing they're not going to go and be lost and be a medical orphan. They have these specialists they can follow up with. And the doctors can always tell the patients that they can contact our study coordinator and we'll get them help too. Long story short, our groups were matched well for age, gender, and ER visits. So this is just an idea of the magnitude of the frequent users we were dealing with. Each group had around 15 visits in the 12 months prior. That's a kind of a moderate ER user in my world. And these are their hospital costs just for ER visits, and their costs. They're not reimbursements and they're not charges. We're going to report that later, but we asked the hospitals, tell us what you think these visits are costing for electricity, Band-Aids, labor, the actual cost to the hospital. And so you can see their hospital costs were about the same too for both groups, around $5,500. This is our race breakdown. It happened to work out well. Both groups were equal for race. And so these are our very preliminary results for the 12 months of the trial. We saw a statistically significant difference in ER visits for the two groups in the 12 months of the intervention, 5.59 versus 8.47. That is statistically significant. We're also seeing a statistically significant change in hospital costs of about $1,600. It'll be interesting to see what that translates into for actual savings to the payers. You could say if all these people were self-pay, well, that's $1,600 less that the hospital has to pay, but it's very preliminary on our economic analysis. This is our observations for overdoses. The holy grail would be to come up with a system, an intervention that reduced overdoses, but we knew we probably wouldn't be able to do that, but we couldn't resist trying to measure them, and we really can't make any conclusions here, although you'd like to. The numbers are just really small. You know, there was 2 overdoses here in the treatment group, but that doesn't mean anything just because there was none in the control group. So we just observed them, and there's our overdoses. This is the patient's ER visits throughout the study. The important point is, as you can see at the very start, there's a difference between the two. So as soon as the study started, if you were to go over here, these two groups would be the same. And then as soon as the study started, the intervention group fell off. They both kind of trend downward, but the intervention group statistically stays different from the control group. So we think there's a large statistically significant difference in ER visits. We think there's a statistically significant difference in hospital costs. We can't really say anything about overdoses. I can say that since we submitted these slides about a couple weeks ago for approval, we have done some preliminary analysis on the physician behavior part, which is the prescribing, and I think it's really exciting. We are also seeing a really large decrease in physician prescribing out of this. That's going to be very statistically significant. So we think that these care plans and this methodology really impacts physician prescribing. We had a big deal happen during the study. And you may have heard about this. In Washington, the legislature wanted to save money, and they came up with this 3-visit limit where they weren't going to pay for more than 3 ER visits for Medicaid folks. And really ingeniously, one of our senator ER doctors made this compromise where we do all these 7 good ideas in all the ERs, and they would agree to drop that. And one of them was to use the computer system we were using. Another one was to use the Washington ASAP ER opioid prescribing guidelines. And other things were like to sign up for the prescription monitoring program. So during our study, we feel like the control group and the treatment group had a tremendous amount of pressure to stop prescribing. But even with that tremendous amount of pressure on both groups, there's still a bigger difference on our treatment group. These are some limitations. We did study all the ERs in a metropolitan area, but we did not look at ERs outside the area. We didn't look for overdoses outside the area, and we were very underpowered to look at overdoses. So again, in conclusion, we feel our approach, which is citywide personalized DD care coordination, is an effective tool to reduce ER visits and hospital costs. And we also feel we're going to be able to report in the future it's going to reduce prescribing out of the ER for this at-risk population. Thanks.